parameters are unchanged from the previous tip. The osteotomy is enlarged, again using circular movements. And once again, the integrity of the membrane is checked with the probe. The augmentation material, a beta calcium phosphate product in this case, is mixed with blood from the bone defect and the collected bone chips. The implant center that drives both the surgical motor and the piezotome indicates the level of irrigation and the intensity of the ultrasonic unit. The TKW3 is used to successively enlarge the preparation. It's important to work in a controlled manner and to exert low instrument pressure in order to avoid perforating the membrane. Once again, the integrity of the membrane is checked. Both osteotomies now clearly show the intact Schneiderian membrane. The next to last tip, TKW4, enlarges the osteotomy to accommodate the key instrument TKW5. Also known as the trumpet tip. The instrument settings are still for maximum irrigation and maximum amplitude of the piezo signal. Yet again, the integrity of the membrane is checked. You can see the preparation and the intact membrane. The diameter of the osteotomy now matches that of the trumpet TKW5 tip. TKW5 also has the same 2 mm laser etched depth markings. The lowest ultrasonic power level, D4, is selected. The irrigation setting is reduced to 10 milliliters per minute. The trumpet fits the osteotomy exactly. Gradually increasing the flow rate and the ultrasonic power detaches the Schneiderian membrane from the bony floor of the maxillary sinus. Holding one of the osteotomies closed increases the vacuum in the other. Here you can see the membrane, which is already slightly detached. To avoid rupturing the Schneiderian membrane by introducing the bone replacement material, which may sometimes have sharp edges, a collagen fleece is introduced into the osteotomy first. The TKW doubles as a condensing instrument. Careful wetting of the tweezers with physiological saline solution keeps the material from sticking to the instrument. The Valsalva maneuver can also be used to check the integrity of the membrane. Simply ask the patient to hold his or her nose and exhale. If no air escapes from the osteotomies, this means that the mucosal membrane is intact. An application syringe is used to fill these osteotomies with the augmentation material. The trumpet serves as the condensing instrument. Once the augmentation material in the osteotomy has been condensed to the point where no more material can be introduced, the time has come for the plug and spray technique. Choosing the lowest flow rate for the saline solution, 10 milliliters per minute, and the lowest power level for ultrasonics to mode D4, depressing the foot switch for 1 to 2 seconds will move the augmentation material further into the subantral space. At this point, additional augmentation material can be introduced. The amount of material that can be used is determined by the residual bone height and the number of implants needed. Now, a 4 millimeter implant, 11.5 millimeters in length, can be inserted. The prerequisites are primary stability and the torque of at least 30 Newton centimeters. The implant is inserted at 20 RPM without irrigation. The previously removed mucosal plugs are shortened as required and sutured back using an atraumatic monofilament thread. The atraumatic procedure using the intralift allows a safe and gentle augmentation of the maxillary sinus floor and spares patients the pain and agony they would otherwise have to suffer in the modified conventional procedure, according to Tatum, where the maxillary sinus is accessed through a lateral fenestration. The post-operative radiograph shows where the sinus floor has been elevated. The implant inserted at Site 1.5 is also depicted clearly. Actually, I feel very good under the circumstances. I did not have any pain during the procedure, and I was glad that it did not take very long, and I would not hesitate to have it done again. Yes, the operation was very successful because there was very little bleeding, which was easy to see. It is also the reason why the patient will really be feeling very good today. We simply did not cause any major trauma and did not make any large cuts. During the operation, we could see that the mucosal membrane at the bottom of the sinus remained intact. And on the post-operative radiograph, we were able to see a lot of bone replacement material that we introduced. In that respect, we can call this minimally invasive procedure, and specifically today's operation, a great success.